Hello, welcome everyone to this exciting topic. We have guests that are clinicians, that's the founder of products that can actually help and address the topic at hand. We are talking about healing with less pain and scarring after surgery, specifically after our pelvic and abdominal surgeries that are very common, especially with women around this time. This is being recorded around November and December when we are in a high volume period for surgeries of this kind that we know involve a long recovery, as well as give us time during the holidays to heal and recover. Problem is are we being given all of the information after surgeries that really do have long-term consequences for some of us, depending on our skin types? So we're going to actually talk, with this panel. I'm going to go around and have you all introduce yourselves. I'm so excited that you're here. We're going to actually first start with Dr. Janelle Brown. Dr. Brown, will you introduce yourself, please?
Good evening. I'm Dr. Janelle Brown, physical therapist specialized in pelvic health from Pompano Beach, Florida. I'm excited to be here and definitely have a passion for teaching and helping others learn about other ways for pain relief, and excited to get started.
Excellent, excellent. Thank you so much. And next we have Dr. Ukpe Wallace. Will you introduce yourself, please?
Yep. Hi, my name is Dr. Anitia Upa-Wallace, and I am a public health physical therapist located in Oakland, California in the Bay Area, specialized in pelvic health, visceral mobilization, and also pregnancy loss advocate, and do a lot of work as well.
Excellent, excellent. And I'll definitely want to explore a little bit of, more about what you said about pregnancy loss at the end. Excellent. And we have Arthur Toole with us as well. Thank you so much for joining us. Please introduce yourself.
Thank you for having me. My name is Arthur Toole. I am co-founder of Meg Relief, which is an all-natural pain relief solution. And we partner with physical therapists, occupational therapists, and other healthcare practitioners to provide natural pain relief remedies for their patients.
Excellent. So we just kind of bringing you all together. This is really centering around a specific story that Dr. Brown shared that I came across, and I just, said, how many people really would benefit from knowing this story? And again, just being cognizant that, these are real people that we're treating, that we're engaging with, but who are on time and time again, as a pelvic health therapist, we're encountering people who are just not given information in a timely enough manner. So Dr. Brown, would you share the story that really brought all of us together in this topic tonight?
Of course, of course. So about, I say 3 to 4 weeks ago, I had a patient, an older Black woman, about 66 years old, who was having chronic pain, shooting, burning pain into the vagina, low back pain. It was just going on for years. She couldn't figure out why. They meaning like her other physicians, tried to push for hysterectomy because they're like, look, we've explored all options. We honestly don't know where it's coming from. So previously she had a gastric surgery for weight loss, and they also cut off some layers of skin, stitch her back up, but the scar, the incision, it went all the way around from her back to her other side. It was just very, very poorly put together. So when she came in, I just started laying some hands on her, wanting to explore all options. So started doing some scar work, and she jumped and she screamed almost off the table. And I was like, what's wrong? What's wrong? She's like, that's the pain. That's the pain I've been feeling, the vagina pain, the shooting, the burning, the back pain. That's it. So she starts crying, and I'm like, okay, what's wrong? She's like, I thought I was crazy. And she just starts thanking God, because she's like, now I know there's a cause for this. Like, she was concerned there was a deeper rooted issue with her health. So once we figured that out, she's just thankful she didn't get a hysterectomy, just thankful that she didn't have to go crazy anymore. So we found out that scar was really the root of her pain.
Could you imagine if she would have gone with even a more extensive surgery?
Mm-hmm.
Right? Dr. Anieti, can you please explain a little bit about what you do a little deeper? Now, I understand that you mentioned that you work with moms postpartum who have suffered miscarriages, losses. But in terms of just the physical ramifications of surgery after surgery, scar tissue that's affected, nerve pain, all of that, how do you approach the mental aspect of some of these conditions that you see?
Yeah, well, I think, with Dr. Janelle's patient, like it's very, a lot, scar tissue definitely will proliferate, whether it's, through the skin layer, through the fascial layer. It can affect the nerves. Nerves don't like to be stretched. They don't like to be compressed. So, and especially given that was having some of the pain like into her genital area, along her back. And so like, yes, it's understandable for a patient who's having like all these different weird symptoms that could seem really unrelated to the surgery that she had, but knowing that with scar tissue, I like to think of it almost like a spider web, and it just like sends out these tendrils, to wherever in the body, and it'll just kind of anchor and it'll hold there, and they'll just kind of continue to grow. And then that will create a lot more restrictions. So, I think with, first of all, like, just educating that patient and letting them know, like, this is what's going on, what scar tissue is, like how it's affected, that we can't get rid of scar tissue, but we can help to soften it, and that it's a process that both, working with the pelvic health PT, as well as, a lot of self, massage, and there's lots of techniques that the patient can do themselves. And that just really helps to empower them so that they realize like, yeah, the power is in my hands. Like I can be able to help treat myself. I think is such like a huge component, and then just provides like so much relief. It provides them with the advocacy so they can, speak up for themselves, especially when they're at their doctors. And I think also for them to realize, that that there is healing, that can happen, within their own hands as well too. And that just makes them just so much more, build more awareness around their own body, having more, just general awareness of like when things are going wrong, for them to be able to, learn more about it, or, seek out a professional who knows what they're doing. Obviously, I know the MDs are great and they're really helpful, in certain conditions, but, with others, I mean, it's terrible that they recommended a hysterectomy, because another surgery would have just brought on more scar tissue as well too, and then she would have just been, in even more pain, which was probably unnecessary. So I think on that mental health component, just for them to build that awareness, realize like how much healing that they can be able to provide for themselves is huge.
And that's the thing. A hysterectomy was recommended to her. So another surgery and a removal of an organ that actually, helps to produce the hormones that's needed, for healing, for maintenance of our bones, our collagen, all of it. So just bring me back a little bit to this patient, Dr. Brown, if you can. You started working on her scar tissue, and she like pinpointed this is what the issue was. If you can like go back in time, how early would you have wanted to see her after her initial surgery?
I would have wanted to see her right away. They say about 6 weeks after a surgical incision to really heal. Everybody varies, but generally about 6 weeks. I would have wanted to get in there as soon as I could have, before the adhesion started, before the nerves got involved, before pain radiated transfer, before trigger points got involved. She would have had a much better outcome, in my opinion, and she wouldn't have had to deal with years of uncertainty, just going crazy, just it could have been a better situation. It could have been avoided.
Absolutely. And both of you can chime in that, are actually, doing this work now. Would you say even 6 weeks is a little bit too long?
I mean, I would say, generally, like to do like the hands-on work, I would say like, yes, about 6 weeks, you want to make sure that the incision is fully healed. But even before the surgery, I mean, there's a lot of breathing techniques that can be, extremely helpful, that can be done soon after the surgery when they're feeling up for it and, feeling, having energy and stuff. But just working on diaphragmatic breathing, just because, being able to get that diaphragm to expand, that's going to have a huge almost essentially like getting an internal massage and work on getting movement, through all of the organs and through, all of the fascial layers. I think that would just be, if the patient was educated, and a lot of doctors don't really educate their patients about scar tissue work or like scar tissue or things that they can do in order to help themselves, soon after the surgery, that, even if she did have to wait several years, and if she knew like, okay, this is something I can work on, and if she didn't know, much else than that, that probably would have even lessened just some of that pain that she was having. So
And I
agree.
think rehab is really important.
Mhm.
Even like with certain people who get their ACLs done, they go through prehab, just getting the body prepared, so there could have been core strengthening to make sure the abdominals weren't so weak afterwards, just to avoid some of those post-surgical problems.
Right, right. Arthur, you said that you work with OTs and PTs. Is that right?
Yes, that is. But before I comment on that, I want to just say thank you to Dr. Brown and Dr. Upe Wallace for what you all are doing and how you all are focusing specifically on the moms and the pelvic health, and especially the post-delivery. I say that as not as a CEO, take the CEO hat off, but as a husband. My wife had C-sections for both our kids, and we were not introduced to a physical therapist. And so all the things that you all are talking about, the pain, the scars, she had all those things, and she went around for a couple of years with this pain, not knowing what the cause of it was. And unfortunately for her siblings, they all had hysterectomies. And so she just assumed that was going to be the next step. But fortunately, we engaged a physical therapist that steered us to a different path. And so that was part of the introduction to Meg Relief. We were using Tylenol, we were using, opioids for a second, but none of this stuff really answered the problem. So my wife is from Grenada, and we started there, and we took some of the stuff they were using naturally there for her lower back pain, and that provided the relief. So that's what we decided to partner with physical therapists, the one that gave her some relief, and occupational therapists, mirror that with what we were doing, and that's how we're serving moms. But it all started from what you all are addressing. We had my wife had childbirth. She had to have a C-section. And now, armed with the knowledge that we have now, we don't even know if she had to have a C-section. We just know that because the physical therapist wasn't there in the room, we were told, hey, a C-section is the thing that you can do, and we just did it. But now we're able to help support you all in helping the mom. So I'm grateful to be on the call for that.
And Arthur, you're not a clinician.
No. My wife and I were both prior military. My actual background was in finance and banking. It's just that we had nothing that would help, right? And so the Tylenol wouldn't help, the ibuprofens wouldn't help. And then when you look at the risks that are involved when you're taking these things, sometimes the risks are way more than the problem that you're having. And then when they were putting her on opioids, I asked one question. Again, this is a layperson. Okay, we're putting her on this. When do we get her off, right? Because I'd had surgery in the military before, and my mom is an occupational therapist, and she wouldn't allow them to give me opioids because she was like, you may become addicted. I didn't understand that then, but that always stayed in my mind. And the doctor's response, well, we'll deal with that when it comes. So in my head, we don't know the answers. You want to put my wife on, opioids, she may become addicted, and this is where we're going to stay. So it kind of started us on this journey. So can we answer the pain problem with a natural way that doesn't have the risk of like the Tylenols and the ibuprofens, and doesn't have the addiction of the opioids? And then can we partner with the people who are solving the problem at the problem level, PTs, OTs. And so that's how we got on this journey.
This is not the first time I'm hearing this, but all of you in some way, shape, or form have said that had physical therapy started earlier, we could help people avoid not just chronic pelvic pain, but hysterectomies.
Yes.
Unnecessary surgery.
Yeah. It's baffling to me that you all aren't introduced earlier in the process. Every person in my life, every adult in my life has been impacted by a physical therapist. But I was exposed early because of my mom. And I don't want to speak for the doctors you have on the call, but you all are critical. But we don't, as lay people, we're just not introduced to you all soon enough. we have the pain. We go see the doctor. The doctor tells us you have to have surgery. And as lay people, we just say yes, not knowing that half of the stuff that they're telling us can be, remedied if we just were connected to a physical therapist.
Let's talk about skin, specifically. That's, I don't know if it's fair to say that skin types are more at risk, or just negligence in general will cause, certain people, certain demographics to just wait too long until they're developing all of these issues. So let's get into the nitty-gritty of skin, of Black and brown, beautiful skin. And I have to speak from someone who now is working in a very rural, predominantly white area, where it's not necessarily widely available and known that our skin doesn't turn red in the inflammatory state. Like, we're still on that level, of just understanding that our skin types show up differently after these procedures, and infection is often missed or delayed in terms of treatment. So let's talk about your experience with that, if we can. Dr. Upe Wallace, please.
Sure. Well, I could at least speak to, in regards to the skin color change that can occur, especially if there is an infection, or if there is, for at least a person who's Caucasian, where it would turn red if there's like any type of irritation or infection. For those of us, of color, it's going to turn more purplish. I would say like purple, like a deep type of red, maroon type color, especially if there is, any type of irritation or infection. What I have seen for those, those of color who do have scar tissue, like the biggest thing that I see are usually like keloids. And so keloids are just more, so when scar tissue is laid down, so there is just a haphazard laying down of collagen fibers, kind of like if you dropped a bunch of matchsticks on the ground, and then it's just a haphazard, laying down of that collagen fiber. And so obviously over time that, tends to increase, and it creates a lot of tension in order to help to keep that skin integrity, or not just the skin, but also all the other layers underneath it, but just to maintain that integrity. And so in some cases there could be just like an overgrowth of that, collagen fiber. And then in certain areas, keloids, which are just, if you looked at it, it's almost like little bumps that are formed, along the layer of scar tissue. And especially for a lot of women of color who I have treated, whether it's like big vertical scars, from like a gastric bypass, or, from a gallbladder removal, or from, hysterectomy or C-section, that can, have a huge impact, in regards to how quickly the scar tissue, lays down, in regards to just the healing process, and then any other underlying issues that they might have, especially just like whether it's wearing clothes or wearing tight fitting clothes, and then having just that, constant contact, on that scar tissue can create a lot of irritation, and then, create a lot of issues or pain, over time. So that's one of the things that I have seen in my practice. And yeah, just again, like just kind of speaking to what I spoke to earlier, I think in general, there just isn't a lot of, talk with physicians, to their patients about what will happen after surgery. But I think even more so for people of color, in regards to how to take care of their skin, how to take care of that scar tissue, soon afterwards. I had a patient, and I really don't even remember, I don't even remember like whether, Caucasian or Black, but I just remember that they had a surgery, scar tissue was laid down, they were having a lot of issues with it. And they had asked their doctor, like, can I put anything on it? And the doctor said, no. Like, I think this patient was like, just intuitively, it was like, I need to put something on it. It's like dry, it was like cracked, it wasn't feeling good. And they asked their doctor and said like, no, don't put anything on it, whereas like you'd want to like lubricate it, or at least create some type of moisture just to kind of allow that skin to be a little bit more elastic. So, which is kind of weird, and again, until that scar tissue is healed and the incision is closed. But yeah, I wish that more people would just really listen to their gut, and trust their intuition, in regards to their own healing and how to help their body and help their tissues, because sometimes the doctors don't know all the answers.
Sometimes. Most of you know by now. So I have treated in the hospital after hysterectomy and after C-section. So we're talking about 24 to 48 hours after surgery. And I've seen women sitting up in bed, and if they had a pannus, that's that extra fold of skin, you know, that folds over into this incision, they're not even sometimes coached on having a pad that can wick away that extra moisture, that perspiration. And so you're talking about clothing that can rub against, or, you know, lubrication, or all of these things. And it's just like, wow, we can't even coach someone on alleviating that area where it's actually a breeding ground for infection. Right? So Dr. Brown, in that case, what would you want people to know within the first 2 days, even if you're not putting your hands on them until week 6 or week 8, until that scar tissue is healed? What can people know at least in the first 2 days after these major surgeries?
Well, like going back to what you said, I think they should be informed on what type of environment does bacteria like, you know, what type of environment can an infection be created, and then they're more likely to avoid that. So, you know, dark, moist, cold areas, they won't wear certain clothing, or, you know, be in certain positions, lie in certain positions to avoid that. So I think that can be something very simple, just simple education to give to the patient that anybody would understand. You know, you don't want an infection. This is what can occur. This is what you should look out for. So I think those are some things that definitely can be done.
Okay. And Arthur, Dr. Brown was talking about this woman who had radiating pain in other areas of her body, right?
Right.
The product that you have, if you can talk a little bit about that, people want and need something, right? They want some relief, and they don't always want to be given opioids, which can affect their gut, can affect a lot of different things. And so, like, how do you navigate people who are like, give me something now, and they're still at week 3?
Yeah, so that's a good question. So as long as, like, we'll take the scar tissue, as long as it's closed, and so it's not obviously no open wounds, like for meg relief, because it's all natural, it would work. And so that's why we partner with physical therapists. We go to physical therapist clinics, and we let them try it out on each other, and so they can see. But it's essentially, you know, it works with joint pain, it works for muscle pain, and any type of pain, except for like maybe like nerve pain. It start giving you relief within 3 minutes. So that way, if someone's having a pain in their lower back, they have a pain because of their scars, they have a pain in their joints, or anywhere else because of pregnancy, they can use this, and it'd be more effective. It'd be faster than you would be with Tylenol, and it doesn't have the side effects that you would have with like BioFreeze and Icy Hot. Unfortunately for the industry right now, most physical therapy clinics, if they do have something, they're using BioFreeze. And there's challenges with the effectiveness of it. And then the risk from introducing chemicals to a body that's just gotten through surgery is also an issue. So we kind of answer that.
So I like that you at least mentioned those other products, because when I think of those other products, I'm thinking of someone after a knee replacement or someone after an ACL repair. I might not put a product like that, BioFreeze, directly on their incision, but I am absolutely rubbing the hamstrings, up above on the quads. Sometimes the hip is affected. So all these areas that are affected. So I'm thinking of a cesarean incision, right? That's just going right above, 2 or 3 fingers above the pubic symphysis, that bone. I'm thinking that at least around that area, can't I do something?
Yeah, you know, it's interesting that you mentioned the knee pain. So like, that's one of the things that validated what we had beyond myself, who I had knee pain from a military injury, and that's what we used, but my injury didn't require surgery. Fast forward a year or 2, my mother had to have both her knees replaced, and thankfully post surgery, she had a physical therapist that helped her, but she was taking ibuprofen 4 times a day. And then when we gave her meg relief, she went from taking ibuprofen 4 times a day to taking meg relief, rubbing it on her knees during the PT session once every other day. And so that's kind of things that we do. And one of the advantages of our product is that it contains only like 4 to 5 ingredients on all the various products, and each of them have anti-inflammatory properties. And again, since it's all natural, you don't have to worry about some of the issues that you would have with like the other things. But
slowing constipation, things like that.
But with it was my mom's knee pain. When I saw the change in her, that I knew, okay, hey, this is something that we can really go ahead and push to a larger audience.
Okay, let's talk a little bit. Do any of you, so the clinicians on the panel, have any background in lymphatic massage, lymphatic, just in terms of the lymphatic system? Let's just go basic for our audience there, because they're like, what did she just say? Lymphatic, what is that? So let's just go basic. What in terms of the lymphatic system do you know and that you bring into the clinic and that you educate people about?
Yeah, so I'm not a certified lymphedema therapist, but I do offer just very basic lymph massage and teach patients on how to do lymphatic massage. So the lymph is one of, it's part of the circulatory system. It's one of the ways that the body is able to move out, any type of infection, anything that the body doesn't want. But it needs a way in order to be able to do that. So in a very similar way to like the venous system, where, it's a one-way system, it's also very similar for the lymph. And so it's really like movement, that helps to get that lymph moving. It is fairly superficial. So if you've ever seen like some products for like lymph massage, you're doing just a very light brushing. It's not like deep tissue type work because it does lay, within that superficial layer. But yes, you definitely want to get lymph moving. So, I mean, if I'm thinking of, someone like after breast cancer treatment, then there's usually that tendency for the lymph nodes to be a little bit more inflamed, or even just like a regular, just general like cold. And then you have the lymph nodes along the neck that will tend to be a little bit more inflamed. So you want to get that lymph moving and flowing. And if I'm thinking specifically of the pelvic region, so if you have, the pelvic bone, if you're familiar with like the inguinal ligament, so that's the ligament that attaches from the ASIS to the pubic bone, and then running through that, you have, vein, artery, nerve, and then you also have a lot of lymph nodes that run through that area. So if there's any type of, congestion because of surgery, if there's scar tissue, which is then going to create restrictions, around that pelvic area, then that's also going to limit how well or how efficiently lymph is moving through the body. And again, because it is a one-way system, we do want it to be moving up towards the heart. So that way then it gets circulated out, whether it's through urine, through sweating, or through breathing as well too. So all of those are different ways. And so you do definitely want to do some type of lymphatic massage. I'm going to say like YouTube is really great, but there are some like really great videos that you can find on YouTube that show how to do, just a very basic lymphatic massage. So obviously you want the biggest prime pump that you want to move is obviously the diaphragm, because you have the major cisternic hylae, which is like in the thoracic area, that obviously with diaphragmatic movement, that's going to have a huge impact on getting that duct to move. But then you also have lymph nodes, around the base of your jaw. You have it along your armpit, you have it along your abdomen, you have it at your groin. So working on, I would say like priming the pump in all of those areas in order to kind of help to encourage lymph movement is really helpful, especially after surgery.
Okay, wait. So after surgery, is that still 6 weeks that I have to wait before I can do all of that?
No, because you're affecting like so many other, because it is a whole circulatory, system. So I think it's something that can be done soon after the surgery. You don't have to wait until, afterwards. And especially, so for example, for like a C-section or a hysterectomy. So knowing that, okay, I might not want to touch the scar, but I can work along the groin. I can work along my abdomen. Again, I can work with breathing so I can help affect the movement of lymph.
Okay. We have a CLT in the audience tonight, certified lymphatic or lymphedema therapist. And so I want to go back to everything that you're talking about, because I don't know that you have to be a lymphatic therapist or a lymphedema therapist to specifically train someone in the prehab phase on how to do what you're talking about. To me, this would be very effective. And I'm going to give you an example. How many of you have heard of people developing this like extra layer of skin? They call it either the Cesarean pooch or, you know, an extra belly after a hysterectomy. Like, what is that? Can we argue that that might be a dysfunction of the lymphatic system, especially if this person has not been told, lie flat, do a massage up above around the rib cage, the diaphragm, do a massage down below, and they're in this position? Can that not develop into a fold of skin that wasn't there before? Dr. Brown, you want to, I mean, anyone can weigh in. I do. I want to explore this a little bit. What is that?
So let me just say, I'm not a doctor, okay?
Mhm.
My experience is watching my wife, but I watched every aspect of my wife because I like watching my wife. She didn't have the folds of skin before, and she did after, and it was never addressed for 10 years. So I don't know if that falls in the same category, but I do know exactly how you described it. That's what my wife had.
What
And
if,
so
I want to know if you all believe that that is just a side effect of surgery that people just have to be prepared for mentally, or can that be avoided?
yeah.
I think that can definitely be avoided because, like you said, when the incision, when it's healing and you're in that like hunched over posture, just all day, you know, it's just cramping, leading to that posture. So I think things can definitely occur below the incision, and I've seen it to where it's almost like a dent, and just the tissues are growing around it. It's like a divot into the skin. There's been no mobilization, there's been no stretching, no diaphragmatic breathing. And the deeper that scar tissue pulls and constricts in, the more the tissue under it kind of protrudes out, I think leading to the pooch that you're talking about. So I think that's definitely a possibility.
Okay, so we're kind of getting into this. Always happens at halftime. I don't know what I'm trying to like get it in earlier. Like, come on, let's talk about it. I want to know from you all if prehab is not yet a standard of care for people who are expecting to have their third C-section or expecting to have a hysterectomy or even weight loss surgery. Can we even talk about that? Weight loss surgery is a big deal depending on what procedure you're undergoing. Can we talk a little bit about, in an ideal situation, say prehab kind of coached people through, but now they have from 0 to 6 weeks until they can see a pelvic health specialist. Ideally, what would you want people to know? You know, even if you wanted to do one of you can do the first 3 weeks, the other can do the latter half 3 weeks, and then 6 weeks you're seeing them, you're putting your hands on them. What would you want them to know in that time frame? Popcorn style. Don't all speak at once.
I think I would want them, so prehab wise, like I said before, I want them to know just some different, you know, core work they can do, nothing intensive. Just working on contracting abdominals, working on diaphragmatic breathing, giving that passive stretch. I'm sorry, my dog's drinking water. Giving that passive stretch to the abdominals. I think things like that, positioning. I think that would be good the first 3 weeks.
And you said breathing as well, the diaphragm,
Yeah.
moving the diaphragm. Okay.
Breathing as well, giving some rib movements because things are starting to be compacted. You know, they just went through a major trauma, there was surgery. So getting some more movement into those structures, I think would be good. Yeah.
Okay. All right.
Yeah, I would definitely diaphragmatic breathing. I'm a huge proponent of that. I think movement just in general. So like, you know, if you're not able to get back into your normal routine, walking is one of the best things that you can do because that's obviously going to help with, you know, lymphatic movement, or obviously with overall mental health as well too. I think, you know, doing any type of like gentle stretching, yoga, all of those can be really helpful. So even if you're not wanting to have, you know, work directly on the scar, but just knowing that there are really simple movements that you can do, like whether it's like Sphinx pose, Warrior 1, Warrior 2, just the action, just knowing that, you know, with how scar tissue is laid down and how it's going to have an impact, on that fascial layer, and that fascial layers do connect, so even just the action of lifting our arms up will have a huge impact on getting some like stretch, down below in our pelvis. That just even getting that type of movement can be extremely helpful in an indirect way, and be able to get those layers to be able to soften and, open up as well too. I would invite, like, just even, even if they're not working directly on the scar, definitely around it, again, just because, like, well, definitely, like, after like any type of surgery, you're probably taking some type of medication. Your peristalsis has, been affected. So most likely people are always dealing with constipation. So just even general, like, abdominal, massage, just going in a, clockwise direction, just so that you're helping to encourage, just at the very superficial layer, encourage some type of movement there, I think is one way to start, before then you start to work on a much more deeper, or aggressive way to, get into that scar tissue. So there are little things that, people can do just to help ensure good mobility of their scar overall.
Okay, so let's talk about it. I'm going to talk about it. Arthur, I'm going to bring you in. You are not a clinician.
No.
We have people in the room that are doulas. We have people in the room that are not pelvic health therapists. And we have people in the room who might just actually be preparing for surgery. And they're like, what did they say? ASI? What did she say? The ASIS and the peristalsis? What in the world? Like, we have people in the room who are representing all, I want to say, ranges of understanding of what we're talking about. So if we can break this down, because this is important, if we as pelvic health therapists are not comfortable in intervening and seeing someone until 6 weeks after surgery, can we at least teach whoever is going to be in that room with that person during the first 3 days while they're in the hospital recovering at home? Can we impart enough knowledge of what you just described to someone like Arthur to say, encourage them to do this, encourage them to do this, encourage them to do this, all of the things that you talked about? Or can we step it up and make
So absolutely. So again, the CEO had it sitting over there on the side of the table, and still the husband had his arm. As a husband, I was powerless to help my wife, right? So I saw her go through all the challenges, and then she had to struggle with preeclampsia and all those. And then post surgery, post delivery, she had to deal with all this stuff, and I couldn't help her. Right. And she didn't like the excess weight that wouldn't go away. She didn't like the pain that she was feeling. She didn't like the scar, but I couldn't do anything but just try to encourage her until we came across a physical therapist. And it was a physical therapist that introduced us about scar mobilization. I think someone in the comments also talked about that as well. And that made the scar go away a little bit, or we saw it less. And it relieved some of the pain that she was experiencing. And that same physical therapist taught me how to massage. I'm not as good as a physical therapist, but I was able to learn something, how to manipulate the scar a little bit. And in addition to the medical help, it also helped us get closer again, because my wife didn't even like, being, if I can just be transparent, naked, because she had the scar, because she had the extra layer of skin. And so the physical therapist was able to bring us closer together by teaching me how to serve my wife in a way that I wasn't able to before. And so I think everything that both of the other doctors have said on here, if it's shared with the significant other or with a family member, it would be immensely helpful. Another example is when my mom had both her knees replaced, my sister was there, and the physical therapist that was there, the physical therapist and then occupational therapist taught my sister some of the things that they could help my mom do while she's doing her exercising. And that helped my mom get back on her feet. So I think including a family member is not just a nice to have, but it's absolutely crucial, because that can be that person that supports the overall plan that the physical therapist you all are doing. Because the patient themselves are in pain, and that's just the physical pain. Then they have the emotional pain that they're dealing with as a result of the experience. So involving the whole family and then empowering the whole family with some of the knowledge that you all possess is like the trifecta in terms of recovery.
Arthur, you just touched on a lot with mental health there. I don't even think that you meant to do that. But when you're talking about someone bonding and restoring a relationship, me as a physical therapist, I live for the day that I could actually restore a relationship or someone's mental health.
Yeah.
And so, I mean, I have to like go back. One of our doctors has experience helping people through pregnancy loss, right? And so when you are working with someone through pregnancy loss, not all loss happens through a vaginal delivery. I've seen losses that occur through cesarean section. And what gets one person through a cesarean section recovery is not the same, for someone else, especially if that bond with the newborn is not there, especially if those endorphins aren't being released. So we're not only dealing of the mental and physical pain of scar tissue and healing, but now there's that mental health aspect that if we were to have this person wait 6 weeks before we see them, man, that's 6 weeks that they had to deal with that alone. And they're not always given that rehab. They're not even sometimes prepared for a loss or an unexpected delivery. So I ask you this to really think about this, because we have a phenomenon happening. We're not, every pelvic health specialist now is supposedly a therapist. There's a lot of pelvic health therapists now and specialists, and we can't identify, are they a doctor of physical therapy? Are they a this or are they a that? We do have a phenomenon. I think that we should talk about that a little bit, because at the end of the day, when it comes to post-surgery and healing and recovery, I would say there are experts on this panel, and I would want to learn from you rather than someone who's collected knowledge along the way, but that doesn't necessarily have all the nuts and bolts of what's going on physiologically, and in particular could possibly cause harm if they do some of their techniques too early. So I'd rather have you chime in now, because people are going to look for answers. They're not necessarily going to wait until you say 6 weeks, we're ready to see you. They want answers now. So what are safe ways that we can kind of incorporate this information and maybe even teach our doulas and teach our other providers or coaches or trainers or whoever is out there calling themselves a pelvic health specialist? What can we teach them? Because they are going to connect with these folks who are desperate for help. Dr. Upe Wallace, if you can chime in.
I mean, I think the biggest thing, especially for someone, whether it's a doula, whether it is a coach, a fitness trainer, the biggest thing that I've seen, whether it's dealing with pregnancy loss, whether it's dealing with, scar tissue, whether it's dealing with, a traumatic birth or a C-section, is on how to just reestablish connection with their body. So I think so much with what, Arthur was saying, about his wife and about her not wanting to be naked. And with a lot of patients that I see where they'll say, that they wish that that part of their body was cut off, whether it's because they're dealing with pain or because they don't have an understanding of what's going on, or things just look very different from what it was before. And there's a disassociation that's there. And so just like with, any other part of our lives where, we cut a certain person off, or we no longer do a certain like activity or whatever it is. And then it's no longer present. It's no longer there. It's no longer, front of mind for us. And I think that working on establishing connection is going to be like a huge piece. And the first way to do that, is by touch. And it doesn't have to be, yes, working with a skilled person is so important, but even just by laying hands, just by being able to like lay hands there and just acknowledge, what's present, acknowledge, whether it's the scar, acknowledge, the loss, acknowledge the emptiness. Anything like that, I think, is the first step, because when you have that awareness, then it makes it so much easier for you to then be able to take that next step as to like, okay, what do I need to do in order to, get beyond, or, from this step, what can I do in order to like get to healing? What can I do in order to work on building strength? Whatever that may be. If you don't establish that connection, then there's just always going to be that disconnect. So I would say like, that's the biggest thing. And that is a struggle. It is a huge struggle for a lot of patients that I work with. I mean, especially if they've been, there's body dysmorphia, there's especially in postpartum, whether that's, postpartum is even for those who've had a loss, a way of thinking of what their body was like before pregnancy or before the surgery, because there will be a disfigurement that will happen, and there's a scar that's there that now will disfigure their body. And so, we need to acknowledge that. And I think even as society, just to be able to have this loving and understanding that bodies are different. So I always love, I have my own, my battle scars, from a surgery and from C-section. And so, I love it. I honor it because that tells my story and it's of my experience. And I think, and not saying that that's what everybody has to do, but I think if there was just a general acceptance of that, in society, then I think it would, make such a big difference. And then being able to move forward and move beyond, that disconnect that, is so present. So.
And it will also result in less pain.
Yes. Yeah.
The whole point, right, of what we're talking about. This would actually reduce people's pain and unnecessary pain that we opened the story with tonight with Dr. Brown's client. This woman was in unnecessary pain, and her, the option she was given was a hysterectomy, right?
Like they went to the extreme. And I also say that I noticed a trend with a few patients who have gotten like certain weight loss surgeries, that a lot of them lose sensation below the belly button. And I was seeing multiple people come in with this, and they were just like, I just learned to live with it. And I always ask, were you told this would be a side effect? No. Did you get any help for it? No. So I think like just having that taken away from them, like I'll never be able to feel anything down there again to a certain point, is very, nerve-wracking to them as well. So
is there a way to avoid that? Like nerve loss, sensation loss?
I definitely think there are some things that can be done. So when the scar is forming and when tissues are beginning to adhere, some of those nerve fibers get cut off, or sensations no longer travel to the area of skin when they're compressed like that. So if getting in there, like we said before, doing certain things, doing prehab, doing some scar mobilizations can prevent that adherence of those nerve fibers, just allow them to move freely and, regenerate and grow as they should. So I think that's a way to avoid that.
I think also, because I know, I think it was Catherine was asking, can anything be done for desensitization? So what I had answered was definitely, starting off, and I think like for those who are PTs and, where I know we learn in PT school, like, just starting off with like really soft texture, with fingers, just being able to like touch that scar so that again, when you touch the skin, you touch the brain. That's going to highlight, like, okay, yes, this is an area that, yes, we're not feeling much there, but we want to start to wake that up. Also a big thing that's noted, like for those who've had C-section, because it is right above the suprapubic area or in the suprapubic area. So thinking of the the spinal nerves. So iliohypogastric, is one of the nerves that, is one of from the lumbar spine from L1. So for lumbar spine, so for those who are, part of the low back, but that innervates, into the abdominal wall tissues, and then also innervates all the way through the abdominal wall, all the way to the suprapubic region. And so those nerves have a tendency to get compressed. So even if, working definitely desensitization, but even working on, joint mobilization, along the lumbar spine, even doing thoracolumbar fascia work, like skin rolling along the paraspinal muscles along the lumbar spine, because if there's any tissue or any restriction there, that can also create tension along the nerve. So there's different ways that you can indirectly affect the nerve by not actually touching the scar. So that would be one way to definitely address some of the numbness or the nerve compression that could happen.
And with Meg Relief too, I can just think of having something where we can put on the skin, because people also is that connection or that psychological connection of just, oh, you put something on me, you put your hands on me, you've done something to me. And having that, even if it's away from the area of incision, I believe that it's safe. And so this is my favorite part of the talk, where I actually bring someone on stage to just join and engage with you all, because we don't always have this opportunity, to do that and to ask you questions. But please, if you can, while I bring this person up, leave your information so that people can connect with you in the chat, and I'll make it available for our viewers who are not able to join with us tonight. I'm going to actually bring up another doctor who does, if I recall, does home visits, and that's Dr. Dion Middlebrooks. Thank you so much for joining us. I want to just kind of tap into your brain a little bit. Now that we whet people's appetites, for this conversation, for this early intervention, what would you now add to your practice, that the doctors were saying, that Arthur was mentioning tonight?
One, thank you all so much for the information. Everything is wonderful, and thank you, Rebecca, for putting this on. So this has been fabulous. One thing that I definitely am looking forward to adding, of course, is some of what Arthur was talking about, because it would be nice to have a more natural-based solution for people who are in pain. Especially for individuals who do have open incisions or incisions that have not completely healed as well. One big thing that I like to incorporate, I'm a mobile therapist, so I do travel to my clients and I see my moms usually as early as 2 weeks, but they know I'm able to come out before then if needed. So yes, if need be, we're working on the scar, the incisions right then and there. However, of course, early on, I'm not able to exactly touch directly over the incision. So even with me simply getting a mom in a position, different yoga poses, working on breathing, cat, camel, those things can help as well, because as you're mobilizing the spine, you're indirectly also mobilizing the abdominal region as well. And if I can see my ladies before they have the baby, I really appreciate that, because I really want for them to understand that I understand your birth plan, but your birth plan may not go according to how you have it planned. And if that is the case, you have not done anything wrong. And it does not mean that you have not maintained a healthy pregnancy and that your baby won't be healthy. Just know that sometimes things just happen. So even with your birth plan not going according to plan, let me prepare you. I know you want to have a natural birth. I know your goal is vaginal. However, if a C-section does occur, I need for you to make sure that in the hospital, the person who is there with you is able to say, this is what I need. This is what I was told to do. And if that's not happening, hey, give me a call. And that way we can at least try to figure out and problem solve if we can get the care that you need. Because there's so many women who don't have planned C-sections. Yes, there are some who do, but I think the biggest issue is that when you're not planning for a surgery, you don't know what questions to ask and you don't know what's available. So I think even just letting people know, we're still planning for you to have the birth and delivery that you desire and that you want. But if by chance you do have to have a C-section, these are just like, give them 3 steps to take. That way they at least have that information so they can build upon that. So that way when they are released to go home, they at least have more information than what they would have, because that's the biggest issue I see, is that women just aren't educated. And when they have a C-section, they're in shock, they're discouraged, they feel as if they failed, and it's trying to uplift ahead of time, more so going to that preventative or wellness base, which unfortunately it's in our scope of practice, but we don't claim it. So we need to do a better job of claiming that as well.
I love that. Thank you so much for bringing that up. Just the pure shock of it all. I mean, we could talk about weight loss surgery, and there's some planning, maybe some preparation for that. You can even say hysterectomy. Maybe there's some planning, preparation for that. But these emergent C-sections, I don't think that even us as therapists really realize, what our clients are going through in that really early period. Arthur touched on so much, but then, I'm just shocked to hear his wife went through that for 2 years, right? Before finding a therapist to alleviate and dispel all of these, like, probably self-doubt, like, is it me?
10 years.
You said 10 years.
10
years. I heard 2 years because I couldn't believe.
My wife,
oh, wow.
She walked around with the excess belly weight, the pain from the scar, before we understood. Like, no one told us about fascia or scar mobilization until that physical therapist came along. And so even with the MEG relief, while it relieves some of the pain, MEG relief isn't the answer by itself. It is paired with a physical therapist, because you all bring the expertise to the table. So you all come in and bring the expertise and the knowledge, and then the MEG relief allows you to work around the person, especially if they're really sensitive to touch. But it was 10, and we didn't know. No one told us. No one told us anything. So she just assumed this was just going to be a way of life, which I imagine most women are assume. They just assume that this is where it is. I'm leaking now, or I have this pain now, but and unfortunately,
Just a side effect.
yeah,
Yeah.
side effect of having a baby. And I've learned now by watching her and being in touch with more physical therapists now and doulas, that's just not the case.
Wow. I am a certified lymphedema therapist, and I wanted to invite the lymphedema therapist that introduced herself, at least in the chat. Thank you, Dr. Meadowbrooks, to the stage, because I think it's important to kind of close out with, other providers who can help, bridge the gap. You all are doing such amazing work, with populations and we recognize there are not enough pelvic health therapists or even therapists who are trained in these particular surgeries. We get training on orthopedic surgeries, joint replacement. When it comes to pelvic surgeries, it's almost like everybody's left the room. All our professors just left the room. Like they didn't even touch on C-section when I was in school. Yet it's the most commonly performed surgery in the United States. So I want to bring to stage a lymphedema therapist to just kind of close out and really, maybe add just one tidbit to this conversation. Anna Benedict's, right? I wanted to just bring you to the stage a little bit, because you see probably what I see is always that aftermath. We're always trying to pick up the pieces, but we seldom see situations where we can totally reverse those issues once they become out of control. It becomes very much like we're just caring for it, caring for these areas of swelling that are abnormal changes to skin. It's seldom that we can completely reverse the problem. So can you give us a little input of what ideally would happen early on after these pelvic surgeries?
Sure. I'm a pelvic health therapist. I'm a lymphedema therapist. I'm a women's health clinical specialist. I work in Massachusetts at a community hospital. And we're actually in the middle of trying to start an acute care post-cesarean program at our hospital. What I find is that my ideal time to intervene with all of these people is when they're pregnant. I think we're waiting too long to wait until after the baby arrives, because there's no time after the baby comes. I find my patients do best when they learn techniques while they're still pregnant, and then they know what to do themselves during those first 6 weeks after delivery. Because I agree with you, it's too long to wait until 6 weeks after delivery to start doing anything. We need to start intervening sooner. And especially when you have a cesarean, from a lymphedema perspective, fluid can't cross scar tissue very easily. If we can loosen that scar tissue and get that fluid moving, it's going to reduce the swelling. It's going to reduce the pain. It's going to limit the risk of nerve adhesions within that scar tissue, all of which I've seen. And I see a lot of postpartum vaginal deliveries at 6 weeks postpartum, but the cesareans are really getting left behind. And I'm finding that those people almost have more recovery to do than a lot of my post-vaginal birth patients, because there is so much abdominal rebuilding to do. I think it's a population that's really getting lost, and they deserve better.
I agree. I totally agree. Would anyone want to add to that? Amen. Can I say that? Amen. Yes. Thank you, Anna. Thank you. I just couldn't help myself. Thank you so much.
I want to add to the end of that about how post-vaginal births, they often have like less recovery afterwards. And I get a lot of patients that are like, well, I just really want to do a C-section because, vaginal is going to be too much. It's going to be this, it's going to be that. So I think there's a lot of miseducation surrounding the C-sections will be less than me, pushing out a baby, possibly tearing, possibly having an episiotomy. So I think there definitely needs to be some education piece to that there are pros and cons to each type of delivery.
Yeah. I just want to add, just like what Anna said, I think is, absolutely on point. Because I had to have a scheduled C-section because of a prior surgery that I had, so I couldn't go into active labor. But at that time, also, I was, teaching yoga. I was working with, doing a lot of self-massage. So I feel like for me, like I had the tools, like I knew what I needed to do. And I did a lot of work, beforehand in order to prepare my tissues. So that way, as soon as I was able to, I started working on my scar. Like I worked around my scar. I didn't wait till 6 weeks. Like I worked immediately. And I could say that I have at least 99% of sensation back, Whereas like when I work with a lot of, C-section moms, and like there's no sensation, and like tell them like, yeah, I mean, it takes work. I mean, and it's something that I am regularly, it's 8 years out now, but like every now and again, like, maybe once or twice a month, I'm like working on my C-section scar to make sure that it continues to stay pliable and movable. But I think that's, doing the work beforehand, I think is important. Doing the work soon after, but also knowing like scar tissue is always going to be there. Like you can't get rid of it. So it has to be a consistent practice that you're working on. I don't want to say for the rest of your life, but like, yeah, you have to, it's going to be part of your self-care practice, So yeah, I think that education needs to be given to moms beforehand, but also for them to know, like, if they want to be able to like get sensation back and feel things below their belly button, they just have to be really consistent and dedicated, into that practice.
And that's not bad news. I think if you prepare people for that, they'll step up. They'll step up to the plate. They'll practice. They'll do that self-care. It's the ones who are not informed or are informed too late, and now they're picking up pieces. And now they're frustrated because no one told them early on. And so I think the information that you have shared tonight, I think will help many, many, many people who watch this later on. I cannot thank you enough for joining me tonight. If you all in the audience, if you felt that this was valuable information, if you want to see more conversations like this be had in just open forums where we can talk and discuss and give people information that they can use, that they can understand first. That's a big rule of mine, but that they can understand and then they can use and put to practice. I think, please let me know, give me some feedback if we can have more conversations like this, if I can have you all back on and just see where you are in your practices. If you move that 6-week mark a little bit back and you're seeing people at 2 to 3 weeks, like Dr. Dion Middlebrook said, I want to know if this has changed and who all you're helping, and I want to hear their stories. Thank you. Thank you so much for joining me tonight.